I'm a clinical psychologist, and I think extending your concept of colonisation of people's narratives, I think there's also an issue in, if you think about institutional theory, in neutralising allies to those narratives. So I've been qualified for about 20 years now, and remember going in 1991 to the first conference in Britain on psychological approaches to psychosis, it was called, and Marius Romm was there, Richard Bentle was there saying, you know, psychosis has no substance to it, we need to work with people's experience, all of that kind of stuff. What I've seen more and more in supervising trainees and looking at our clinical training, where we were, say, originally 20 years ago, told that you never prescribed a therapy. You worked with the formulation, so what sense did the individual make, what were the key issues for their story, and you worked with whatever they wanted to work with. Now we're prescribing CBT for psychosis, CBT for depression. I've challenged our director of the clinical training course here on when did that happen and when was the decision made by the profession to start prescribing therapies. And I'm quite worried about how the medical model, I'm quite pessimistic actually about how it seems to me that we've got a subtle neutralising of those parts of the mental health services that were supporting service user accounts and working with those and challenging this global evidence-based practice movement. I don't quite know what we do about it, because my concern with the new trainees is they're not aware that this is what's happened.
I think that's a very, very important comment, and I see that as well when I travel around Britain. And I mean, of course, we can see that the reason CBT in particular is adopted is because it seems very clear-cut, because it's inexpensive, and because it can be taught to people in a very minimal kind of training. And you know, as I was saying to Anne earlier, I mean, compared to long courses of medication, CBT seems potentially helpful in the sense that you're at least talking to the person. You're at least...
People, it's the way they talk about their stuff.
Yeah.
Yeah,
it may be very helpful, and I certainly know people who have... We have some CBT in the US, and I certainly know people who have found some of the concepts and the language of that model helpful when they've had, you know, I think one of the deepest difficulties that people have when they have serious emotional distress is that they don't have a language to describe very, very unusual and difficult and painful and frightening and bewildering experiences. And so if they can come up with their own language, that might be especially helpful, but other languages like CBT can be helpful. Psychoanalytic theory can be helpful to some people. I mean, all kinds of different languages can be helpful to people. I think the core of your question or your comment really, I think we all share this concern, is the prescribing of any particular language. So in the same way that I'm sure Liz Pitt would say, I don't want other people to be prescribed my language for how to describe their feelings of suspicion. My language comes from my experience, or Tamsin Knight saying that. You know, here's where, you know, although I'm not a clinician, I am a psychologist, and the reason I'm a psychologist, and I'm a psychology professor, is because I'm fascinated by people's individual experiences. And I think people's individual experiences are quite variable. And I think prescribing anything in a general way is going to always be a problem in mental health, because people's experiences are so different, and what helps one person is not helpful to the next person. Now, I think, you know, compared to lobotomy, CBT is better because it doesn't do permanent brain damage. But I think prescribing anything in a one-size-fits-all is always the problem, but it's always the temptation. We see this in the entire history of psychiatry. It's always been the temptation. Every single method that has ever been developed in the field has had a period of time in which it was the rage, in which everybody said it was going to cure all the problems that had previously been seen. And you know, if you read the literature, you see, and this is somewhat sad to read it from a historical perspective, you see that was said about every medication that's ever been developed. It was said about every form of shock treatment that's been developed. It was said about lobotomy. And again, over and over again, we find eventually people see the limitations of any one approach because there's so much variability in human experience. So in that same way, CBT helps some people, but it's never going to help everybody. and prescribing it in that kind of dogmatic way is deeply distressing because, again, it's not really listening to people. Listening to people is really, and I certainly hear that in your comment, in your own background, that's the key part.
I'm a nurse and a counsellor by background, and I do a lot of teaching of newly qualified practitioners in mental health. And one of the things that surprises me, and I asked a similar question before, but is that without exception, people, when I ask them why they've come into work in mental health, without exception, people say it's because they want to hear people's stories and they're really interested in helping people to move forward. But then there's lots of things within the institutions that stop people from listening to people's stories. And even as you're sitting there and saying about people sitting around and talking about their experience of hearing voices, I think there's a lot of professionals who would be frightened to do that because of the consequence, despite being qualified. And so I think that they do develop things like CBT that prevents them from actually often hearing the pain that somebody's experiencing. And also they develop other ways of, you know, sitting and writing elaborate care plans without the person. So I just wonder what your thoughts are of how they could overcome some of those difficulties, or what we could do within our mental health institutions in the UK.
You know, that's such a powerful question. And here's where, just for one moment, I'll come back to my own self-identification as someone who's not a mental health professional. I feel that I've been, in a sense, liberated as a consequence of that, because I'm not somebody who has to fill out a risk management plan or, you know, some other kind of thing where I'm not a mandated reporter. I'm not somebody who, while I'm listening to someone's story, I'm not thinking in the back of my mind, oh no, they've just said something that sounds as if they might be a danger to someone. What am I going to do? You know, I just don't have to do any of that. I can just listen to them. Now, so I have a tremendous empathy for those of you who are in mental health positions and who do have all those requirements and do have managers who are saying to you, have you filled out that form, and have you done these 50 other things you're supposed to do today besides listening to people's stories, and have you taken account of the things that they're saying that might be problematic? I have tremendous empathy for that. But one of the things I've learned as someone who has been part of a lot of hearing voices groups and has now been in a position of being a co-facilitator of one, I co-facilitate this group with someone who has lived experience. One of the things I've learned from a lot of personal experience of doing this is that paradoxically, it's really the opposite of what all those risk management people think. The more people have an opportunity to talk about their very difficult experiences, I think the less likely they are to act on them in a problematic way. And I'll give you an example of a story that I tell in this book, where someone who was a clinical psychologist who was co-facilitating a group, a hearing voices group, was asked by another professional, you know, aren't you worried? I mean, what if someone says they're going to do something? And this clinical psychologist said, well, actually something like that happened recently in our group. One of the people in our group threatened someone else in the group. And this person who was listening said, oh my God, you know, what did you do at that moment? I mean, did you right away get someone to report to and so on? How did you handle this risk situation? And she said, well, we turned to the guy who was, let's call him the object of the threat, the person who was going to be hurt, potentially. And we said to him, are you frightened? Do you think he'll do it? Do you think he's going to hurt you? And he said, nah, I don't think he's going to do it. And he said it in that, nah, kind of relaxed, I'm not worried kind of way. Now, he was the potential object of the threat. And this psychologist said what was so striking to her at that moment was this guy was much less worried than we professionals were. We were all busy thinking about risk management, but the person who was, at risk didn't feel that way. And in fact, when he said that, it diffused the whole situation. And nothing happened. Nothing was going to happen. And I think one of the things that mental health professionals need to do is to feel a little bit more courageous and to feel a little bit less influenced by this risk language that makes everything feel dangerous. One of the things we know, and here I'll just talk for a moment about my previous book, which is a biography of the psychiatrist and psychoanalyst Frieda Fromm-Reichmann. Frieda Fromm-Reichmann was someone who worked with schizophrenic patients in the 1940s and 50s, before there was any medication. And she worked in a closed hospital in the US where the most seriously disturbed patients were brought for long periods of time. These were people who really, from the point of view of the mental health system, were completely out of control. They were smearing their feces on the wall, they were violent, they were really, really actively psychotic, and there were no medications and no, they could be put in a straitjacket, but other than that, really they couldn't be controlled. And Frieda Fromm-Reichmann was a tiny woman. She was 4'10". And she certainly could have been physically hurt by many people who were supposedly violent or were in fact violent. And her attitude was always, if you convey a sense of not being frightened by someone, especially not being frightened of their internal struggle, they'll calm down and they won't need to threaten you. And paradoxically, that's what happened. Decade after decade, she worked in some of the most disturbed and contested kinds of places, places that other people were frightened to go into. She would go into a seclusion room with a big, violent guy, and there she was, a tiny little woman, and she would sit down and talk to this person like a human being, not like a violent patient. And paradoxically, over and over again, despite what her colleagues thought, what would happen is that nothing difficult would occur. She would talk to the person. And I think that's what we have to remember. Now, of course, if you work in a system, you have to take account of what you're being required to do. You can't act oblivious to that. But you can find opportunities to step outside that whole structure, to engage people directly on their own terms, and to not assume that if they talk about difficult experiences, it means that at that moment they're going to act on them in some problematic way. Because probably the incredible relief that they're going to have of being able to talk about them with someone who is really listening to them is going to make them feel like the last thing they'd want to do is do any damage to that person who is, unlike most other people in their life, really engaging with them and really connecting with them. And the other thing that I've learned from co-facilitating a Hearing Voices group is that one of the most powerful things about peer support, not only in Hearing Voices groups, also in just other kinds of activist peer support groups of service users. When people come to peer support groups, they don't think that the other people in the group are going to solve all their problems for them. They think they're going to come and they're going to share their experience and they're going to get some support, and then the meeting is going to end and they're going to have to go off and deal with things themselves. And one of the things that I've found fascinating and so moving over and over again is that people will come in and will talk about something absolutely terrifying or terrible or distressing or dangerous. Then the meeting ends. Everybody goes home. And they just deal with it. They just do. They pull themselves together and they just deal with it. And the trouble for professionals is professionals understandably think the person is turning to me for me to help them I better be thinking of something to do to help them. And a lot of times, there's actually nothing to help at that moment. The thing to help is to listen empathically and to be there for the person and to let them talk about something they've never been able to talk about. But they don't necessarily assume that you're going to solve their problem for them, even though the whole mental health system is, of course, structured to make it seem as if they're the person with the problem and you're the person with the solution. I think sometimes backing off of that can be enormously helpful to everybody.
I think a mantra that we'll use is are you being with or doing to with an individual, and your position is to be with. And that, I mean, I work mainly clinically with people who've tried to kill themselves within the previous 24, 48 hours. And so I think I'm one of the few people that they can have an open conversation with, because I've made very clear that it is not my job to stop them killing themselves. It's my job to help them see if that's the right decision for them in that moment. And we have a very different kind of conversation, which, as you know, will then reduce the risk anyway, because they feel quite relieved that someone's actually listened. But I think certainly, again, when you have more junior members of careers coming in, they want to do something. I think that used to be my exclusion criteria. If you want to come in to help people, I don't want you on my team. I want you to help people sort out what they would like, but I don't want you to do it.
Especially, I think that's so important, especially because some of the things that have happened to people, nothing can be done to help. I mean, I was in a part of a Hearing Voices group in North London a couple of years ago. In an area of North London where there were a lot of asylum seekers and people who were refugees who had come from absolutely horrific backgrounds of torture. And no doubt that was why they were hearing voices. And there was a woman in our group who described an absolutely horrifying experience that had happened to her. Now, this was a fact of the history of her country. No one could undo that. It had happened. It was absolutely horrific. But our being present for her now in trying to cope with that meant everything to her. None of us could fix that. We could not help that. It was already happened. But she was still alive, unlike, unfortunately, many members of her family. She was still alive, and she was here now, and she was in this group so that she would have 1 hour in an entire week in which she could tell people what it actually felt like to her. And in a positive sense, going back to Anne's question, I think we cannot underestimate how extraordinarily powerful and helpful it can be to people to have that, even if it's 1 hour a week, even if it's talking to you for a half an hour after a suicide attempt. Whatever it is, even if it's saying hello to someone who's, been in a context in which no one thought about them as an individual and only thought about them in terms of their symptoms, and saying, gee, you look great in that color, or, some other kind of comment about their daily life that has nothing to do with their symptoms, their mental health history, or any other thing. That can be enormously important to someone who's seen in only a very, very narrow way.